Hi, welcome to the part 3 of fracture healing. This is pluripotent scalpel with you. So, the complete talk is going to roam around factors affecting fracture healing. Factors affecting fracture healing, this topic can be divided for UG, it's quite simple. These are patient related factors. Undergrad patient UG means, and for undergrad patients, it can be divided into patient related factors, fracture related factors, and environment related factors. Patient related factors could be modifiable and non modifiable factors. So it could be classified into these three things, and we all know that a malnourished patient, a old age or young age patient, old age patient, the fracture healing will be slow. Malnourished patient, fracture healing will be so slow. Old age patient, the fracture healing will be slow. Smoker, the fracture healing will be slow. Alcoholics, the fracture healing will be slow. Good dietary nutrition is necessary. So these are all things which comes into patient related factors. Fracture related factors, a comminuted fracture, a high injury trauma with more periosteal stripping or soft tissue stripping, the fracture healing will be affected. And environment related factors means about the stability which we have given. The fixation related factors, adequate fixation or non-adequate fixation. This much of knowledge is necessary for a undergrad student, while for a postgrad student this topic goes into a lot detail, lot deep, because we have to know the core physics behind fracture healing and the various ways, essentially the non-surgical ways, to augment fracture healing and to treat delayed unions non-surgically, to understand the way of treating delayed union non-surgically. So this talk is essentially to understand this phenomena. What are the ways by which we can augment the fracture healing non-surgically if we have operated it earlier and healing is slow, and we have to uh, increase the fracture healing speed, then what are the ways we can augment it? So the clinical crux will be this only. So now, factors affecting fracture healing. First factor is the blood supply. So as we know, for this reason, we keep on saying that during open reduction, we should do minimal periosteal stripping. Minimal periosteal stripping, minimal soft tissue damage to the surrounding structure, and we should try to retain as blood supply to the bone as much as possible. For this concept, LC-DCP was made, low contact DCP was made, and there was another way. When you're doing plating, when you're opening it and putting an implant, which could cause a decrease in blood supply, we should be careful about periosteal stripping and non-rigorous retraction and non-rigorous dissection, so as to maintain the soft tissue and maintain the blood supply of the fracture fragment. Now, what happens is when the fracture actually happens, the blood flow decreases with vascular disruption after few weeks, which means in stage 2, few hours to days blood flow increases. This peaks around 2 weeks, which is stage 2 of soft callus, where the we all know that neovascularization happen and cytokines get flushed off. It peaks and it normalizes in 3 to 5 months. So we discussed about open reduction. If we are putting plate, we should do minimal periosteal stripping. Now comes the concept of endosteal blood supply. These open reduction is mostly talked about periosteal blood supply. What about endosteal blood supply? So when we do intramedullary nailing, say in a femur fracture or tibia fracture, we used to rim inside first before putting the nail. While rimming, it causes thermal damage to the endosteal blood supply, and it also causes damage to the uh, bone also, which decreases the blood supply of the fracture of the bone or at the fracture site. And secondly, when we are putting a tight canal fitting nails, it also causes pressure on the endosteal blood supply and compromising the blood supply. But this doesn't mean that reaming should not be done or a nail should be thinner. There should be a adequate balance between blood supply retainment and adequate fixation. Just to minimize the damage to the blood supply, if we don't rim and we put a very thin nail, the fixation might be inadequate. But just to put a very thick nail, if we rim too much and put a broadest nail available, we might devascularize or we might cause more thermal damage to the bone. So you have to find an adequate balance between the blood supply. You have to retain whether you are doing open or close. In open, no much of the no inadequate, no what you say, extra soft tissue stripping should be done. While you're doing it close, you should not try to put a very thick nail. You should try to put a nail of adequate thickness required for the fracture fixation. So here, rimming compromise 50 to 80% of the blood supply of the cortex. Looser fitting nails allow quicker reperfusion to the endosteal blood supply versus canal fitting nail. But again, it doesn't mean that you have to put looser nails, because we have to see both parts. Both affect the fracture healing, not only the blood supply. It's not only the blood supply which is necessary. Adequate fixation is also necessary for a fracture to heal. Now, mechanical factor, bony and soft tissue attachment to the fracture. Mechanical stability which you give it to the fracture. Again, you have to find a balance between the blood supply and the mechanical stability. Location of the injury, whether it is metaphyseal or diaphyseal, or in a stress area, or in bones where you have retrograde blood supply like scaphoid or talus. Okay, degree of bone loss happened during the fracture. Pattern of injury, whether it is a simple transverse or oblique fracture, or whether it is a long spiral fracture, or whether it is a fracture with third piece. So this, when it is a 3-piece fracture, this intercalary segment tend to have compromised blood supply. So there are chances of non-union more in these kind of fracture rather than a simple transverse and oblique fractures. External fractures. Now here come how we can augment the healing and the procedure which we can use for treatment of delayed union or non-unions. First external fixation is low intensity pulsed wave ultrasound. This pulsed wave ultrasound is important. Continuous ultrasound doesn't actually gonna promote healing. Pulse wave ultrasound gonna promote healing. Exact mechanism how it heals the fracture is not clear, but it is supposed to do 3 things. These 3 things it's supposed to do. First, alteration of the protein expression, elevation of the protein expression, and elevation of the vascularity at the fracture site. These are the 3 things it's supposed to do, and it also causes development of mechanical state gradient. That low pulse ultrasound, development of mechanical state gradient, because it is pulse, it is intermittent. So intermittent strain gradient causes endochondral ossification, which the chart we read in the very first part, the chart from the Campbell, which we read in the very first part of the fracture healing. If it is intermittent, is called endochondral ossification. If it is continuous, then it will lead to cartilage formation, which will not ossify. So intermittent pulsed ultrasound is necessary. It accelerates the fracture healing and increase the mechanical strength of the callus. The beneficial ultrasound, what is beneficial? 30 mW per centimeter square pulse wave is necessary, and it was in a study, it was shown that the healing rate of the delayed union and non-union was reportedly close to 80%. So theoretically or by study, it has shown that it has a major role to augment the non-unions or delayed union you can do it without surgically, and it might give you results. The patient might be saved from another surgery. Factors affecting continues. So now it's come for the currents. So they are direct currents, capacitively coupled electrical fields, pulse electromagnetic field, and there is one more we'll talk about. So what does direct current do? No, how? What are the stages of fracture healing which we need to know? Stage of fracture first, then stage of inflammation, then soft callus, then soft callus get ossified into hard callus. So what does it do? It decreases direct current do. It decreases osteoclast activity and increases osteoblastic activity. How does it do it? By reducing the oxygen concentration at the fracture site and increasing local pH. Thereby, it increases the hard callus strength. Simple. Direct current decreases osteoclastic activity, increases osteoblastic activity by reducing the oxygen concentration of fracture site and increase local pH. See, this all topics are theoretical. That's why I separated this video from the direct healing video. The next one is capitative electrical current field. It affect the synthesis of camp and collagen, and also calcification of cartilage. So it's basically affect the states from the conversion of soft callus to hard callus. Capacitively coupled electrical field affect conversion of soft callus to hard callus and by affecting the calcification of cartilage. Simple. 2 direct currents done, capacitive coupled electric field done. Pulse electromagnetic, what is do? It is pulsed again, just to remember, intermittent, cause calcification of fibrocartilage. Again, it is affecting from inflammation, from injury and hematoma, then inflammation, then soft callus, then hard callus. Again, it is causing calcification. So capacitive coupled electric field also affecting calcification. This also pulse electromagnetic field also affecting calcification. Combined magnetic field, they affect what? They lead to elevated concentration of TGF beta, BMP, and COX. TGF beta plays a role in stage of soft callus. COX plays a role in stage of inflammation. We all know that. And bone morphogenic protein actually helps in ossification. So it affects all the stages from the inflammation to ossification. Promote fracture healing by causing mesenchymal stem cell to differentiate into osteoblasts. This is again necessary. We know osteoprogenitor cell is mesenchymal stem cell, which comes from 3 sources, which we read in our first video. So we have understand how all these augments. Direct current increases osteoblastic activity, decreases osteoclastic activity by reducing oxygen concentration and increasing local pH at the fracture site. Capacitive electrical current field, again it affecting it increasing collagen and CAMP and causing calcification of cartilage. Pulse electromagnetic field, again causing a help in calcification of fibrocartilage. Combined magnetic electric field affecting 3 stages: stage of inflammation via COX-2, TGF beta stage of soft callus, and BMP stage of hard callus. Simple, understood. It has to be learned. It's nothing like that. Radiation, again a theoretical topic. We'll discuss it later on. Patient factors. Now we all know a malnourished patient will have some issue with fracture healing. So a patient with nutritional deficiency had to be taken care of. Vitamin D and calcium supplement need to be given. Protein malnourishment also decreases the fracture callus strength. So we have to give amino acid supplementation to increase the muscle protein and fracture callus and affect the fracture callus mineralization. Nothing new. Next is gastric bypass patient. Now, these are the patients which do not have, in a Roux-en-Y gastric procedure, they do not have duodenum. Duodenum is essential for absorption of calcium and vitamin D. So what happens in them, because of deficiency of calcium and vitamin D and it is not getting absorbed, these patients go into secondary hyperparathyroidism because of decreased calcium and vitamin D in blood. It stimulates the parathyroid hormone, increases the parathyroid hormone. What does parathyroid hormone do? It causes resorption of bone. It sucks the calcium from the bone and accumulate into the blood. Okay, it increases the calcium resorption of the bone, making their bone very fragile, and if that breaks, the healing of the bone is actually a task. Treat this patient with calcium and vitamin D supplementation. Now, there is one more point, that gastric banding doesn't affect the fracture healing because it doesn't pass the duodenum. Gastric banding is essentially making the stomach smaller by any means. It doesn't bypass the duodenum, so there is no way that the calcium absorption is getting affected. Diabetic patient, fracture healing is affected. How it is affected? What steps it is affected? It affects the remodeling. First, it affects the remodeling. It decreases cellularity at the fracture callus, which is soft callus. It affects stage of remodeling. It affects stage of soft callus. It affects endochondral ossification, which means it affects the formation of stage of hard callus and decrease the strength of fracture callus. So from the soft callus to hard callus to the remodeling, it affects all the stages of fracture healing. Because it affects all these three stages, it takes almost 1.6 times longer in diabetic patient for a tibia shaft to heal than a non-diabetic patient. Smoking, what must it cause? It's very easy to understand. It decreases the vascularity. So at which stage the new vessels forms? It forms at the stage of soft callus. So it inhibits the growth of the new blood vessels and increase the risk of non-union. Simple. Smoker can take approximately 70% longer to heal an open tibia shaft fracture versus a non-smoker. Then a HIV patient. Now the point with the HIV patient that they are associated with the high prevalence of fragility fractures and delayed healing. Why? One, because of they are on antiretroviral medication. Another point is they have poor intraosseous circulation. They have TNF alpha deficiency and most of them are malnourished. Now there are some medication which also affect fracture healing. Bisphosphonates are one of them, are recognized to cause osteoporotic bone fracture on long-term uses, which is again a necessary topic to understand. A subtrough fracture and femoral shaft fracture on long-term uses is associated with them, which are called atypical fractures also. We'll study these fractures when we'll study the subtrough fracture. And recent studies demonstrate a longer healing time for the surgical treated wrist fracture in patient on bisphosphonates. So one of the drug which affect fracture healing is bisphosphonates. Corticosteroids shown to have 6.5 times higher rate of intertrochanteric fracture non-union. Corticosteroids, if we see, it's actually decreases inflammation, steroid decreases inflammation, but it's not that short-shorted affecting that stage only. There are many stages at which the corticosteroids work. Second, NSAIDs, no doubt it affects stage of inflammation, causes COX inhibition, so it must affect fracture healing. Quinolones are actually toxic to chondrocytes and diminish the fracture repair. So chondrocytes, it affect the stage of soft callus. Now this is a slide which is also important. A fracture to heal require vascularity. If we fix a fracture thoroughly, it needs to be mobilized to increase the vascularity. But that increase in mobility should not be that much that it may fail your fixation. So the movement of the limb increases muscle activity and stimulate vascularity and stimulate callus formation and prevent thromboembolic complications. So that's why you should mobilize your patient as soon as you operate them. But one has to find what is the adequate range of mobilization required for the patient at particular time. Okay. Now movement of the limb, low intensity pulse wave therapy, local biological enhancement, you can use bone graft, you can use BMPs, BMP2 and 7 and growth factor like PDGF. Systemic enhancement, you can give PTH or neuroproteins to the patient. Now this is a technique which is called RIMA respirated instruments. You insert a rimmer in the canal and you aspirate the bone graft from the canal. This is a diagram from Campbell. Now we know patient age is a factor. Older patient fracture will heal later on. Hormonal status is also important. Later on, menopausal patients have chances of more having IT fracture and distal and radius fracture. And because there is calcium imbalance in those patients, so there are chances that the fracture will heal delayed. Level of energy trauma imparted, it actually, the level of energy is correspond to the soft tissue which is stripped out of the bone. So it is kind of proportional thing to the damage to the bone and decrease in vascularity. So directly indirectly injury affect how the bone's gonna heal. Comorbid medical condition, if a patient is diabetic or HIV patient, we know that it's gonna affect growth factors. We talked about types of bone affected, whether it is metaphyseal bone, diaphyseal bone, or it is a bone with retrograde blood supply. Extent of bone loss in anatomical position, stability of fixation, health of soft tissue envelope, sterility, whether it is a closed fracture or compound fracture. Compound fracture tend to go in infected non-union more often than the closed fracture. Cigarette and alcohol use is local pathological condition. If patient is having locally any infection or tumor, then the situation goes around vascular injury or not, how the nerve is functioning, what is the nutritional status of the patient, and what the functional level of the patient. So this is the statement which reminds me of what we are and what we are not. That bone healing is a cascade of biological event leading to the restoration of the continuity of the mechanical properties of the bone. Whether we do anything or not, if bone is attached to itself, bone is gonna heal. We just play a role of a catalyst for the bone to heal in desired anatomical position. It's gonna heal anyway if the bony ends are in contact, whether it is unite nicely or malunite like this. So thank you. We just fix the bone at the desired anatomical place, but it's gonna heal by various factors, some of which we know, some of which we know, most of which we don't know. Thank you. Signing off with the section on the fracture healing.